I'm Dr. Cassie from Vetfolio and the host of Vet2Vet. Today we're talking about Cushing's disease and gathering up some of those pearls of wisdom that can help general practitioners when we're faced with this diagnosis. Joining me is Dr. Patty Lathan. She's an associate professor of small animal internal medicine at Mississippi State University. Her primary interest is endocrinology, and she currently serves as the president of the Society for Comparative Endocrinology. So, Dr. Lathan, Cushing's disease is definitely something you've spent a fair bit of time studying. Thank you so much for being here.
It is. Thanks so much for inviting me. I know that it's one of those diseases that if you don't spend your day thinking about it, it's pretty tough to try and figure out how to diagnose it and treat it appropriately.
This is true. And I have to say, I don't spend a lot of my day thinking about it. I try not to.
I always tell people, if I get into the mouth of an animal and I'm looking at the teeth, I have no idea how to pull teeth. I don't know how to do surgery. I don't even know what to do with skin disease, except sometimes a little bit when it has to do with Cushing's. Other than that, not good at that type of stuff, but I think about Cushing's and Addison's and diabetes a lot. So I'm happy to help people with it.
Cushing's disease can present with, kind of really vague clinical signs, but there's a few characteristic symptoms that we do see commonly. So can you remind us the types of clinical signs, maybe lab work findings, things like that, that would make us be suspicious of Cushing's disease?
Yeah, I think by and far the biggest client complaint when they bring in a dog that ends up being a Cushingoid dog is that the dog is polyuric and polydipsic. They're drinking a lot, they're peeing a lot. It may be that the dog is making the owner get up in the middle of the night to take him outside a lot, or the dog may be having accidents inside that the dog didn't used to have. The other thing that we'll see sometimes is, you have female dogs who have incontinence when they're younger, and then they're treated medically and they seem to be doing fine. And then suddenly the complaint when the dog hits 10 or 11 is the dog is now having breakthrough incontinence. And the first thought is, well, the drugs aren't working, it's getting older, when in actuality, you do some testing and you're like, oh, I think the dog is actually polyuric and polydipsic, and the drugs were good enough to deal with the bladder that wasn't full all the time, but now the dog's drinking so much it's incontinent. So polyphagia is noticed in some dogs. I mean, I think most dogs that do have Cushing's do have polyphagia, but these days, I think most of our dogs have polyphagia. So it's kind of hard for owners to parse that out, but it may be getting worse. And we were talking about, we both have Labradors. I mean, my Labrador, he gets polyphagic, at the sight of a little treat. So I don't really know how to interpret that, but some dogs, especially the smaller dogs that aren't normally polyphagic, you'll notice that. So those are really the biggest signs I think that owners notice. Occasionally we have dogs that come in because they're panting, but Those are the biggest. Dermatology, of course, refers us cases now and then because the animals either have recurrent pyoderma or really bad pyoderma, or they may even have some calcinosis cutis. And if you have a dog that presents that ends up having calcinosis cutis, the number one differential, of course, for that is going to be Cushing's. Blood work wise, I think the things that people notice the most are going to be the increased ALP. That's what sticks out to people. Additionally, the cholesterol is usually high, but that's not something that most people really trigger on. We talk about, stress leukogram. Again, I don't think that's something that most people notice. Really, it's the ALP that people notice. The other thing that I do like to mention is the low specific gravity, or isoscenuric specific gravity less than 10-20. The vast majority of dogs with Cushing's do have some form of PUPD. The thing is that owners are owners, and I'm one of those owners too. If your dog has gradually been getting more PUPD over a 3 or 4 year period, which sometimes I've seen in these dogs, the owners may not notice that the dog is actually polyuric and polydipsic, but then you check the specific gravity and it's 10-10. And then along with that ALP that's high, you look at the low specific gravity, and then you look at the dog and go, I think the dog's kind of got a pot belly too, and it's panting a little bit. Even though the owners hadn't noticed the PUPD, the specific gravity and all the other stuff kind of points towards actually the dog is PUPD. And the owners notice that after you start treating him for it, and they're like, oh, he's suddenly not drinking as much as it had been. So those are really the common signs and blood work abnormalities we'll see.
Sure. I'm thinking of how, like you said, sometimes when these symptoms, they come on very gradually, it kind of falls back to us to ask those probing questions. Like I had one dog I still suspect is cushnioid. I have not proved it yet, but one of the things was we were talking in the room and, we'd kind of talked about, is he PUPD? We're not sure. And it was kind of the same thing of maybe it just came on really gradually. And the owner mentioned that, he jumped up and he stole a sandwich off of his desk. And it was kind of this funny story that he was telling. But in my mind, I said, has he ever done that before? Is that a new thing? He said, yeah, actually, it is a new thing. And I said, we really might be here. So, maybe one day I'll prove that one is cushnioid.
Yeah, I think a lot of it is the things kind of all come together. So they may come in because they're PUPD, but then you start asking these questions, as you said, oh, the dog is not a Labrador and doesn't usually steal sandwiches. So maybe this is adding some more evidence to our diagnostic.
Yes, they don't exist in a polyphagic state like that, like the Labradors do. So talking about proving it and, wanting to really get to the bottom of why these signs and symptoms are happening, if we do suspect Cushing's disease, can you talk to us about how we approach getting that definitive diagnosis? That one's not always straightforward either.
Sure. I think that getting a definitive diagnosis is one of the most frustrating things for a lot of veterinarians and sometimes owners as well, especially if the first test doesn't quite give us that answer. We have multiple tests available. The most common ones that we'll use are going to be the low-dose dexamethasone suppression and the ACTH stimulation test. People talk about using the urine cortisol creatinine ratio, but honestly, because that test is so nonspecific, meaning there are so many false positives, I don't run the urine cortisol creatinine ratio unless I have a dog where I really don't think it actually has Cushing. So a negative urine cortisol creatinine ratio tells us something, but a positive one just tells us we need to do another test for Cushing's. If you have an owner that insists because the dog has a high ALP that you need to test for Cushing's, even though you don't think the dog has Cushing's, you can run a urine cortisol creatinine ratio. And if it's not high, then okay, you've proven to the owner dog doesn't have Cushing's. Now, if you really think the dog has Cushing's, my favorite diagnostic test for people in general practice is going to be a low-dose dexamethasone suppression test. The low-dose dex to me gives you the best bang for your buck. It's very sensitive. So if you really think the dog has Cushing's and it's checking all the boxes and the dog doesn't have any other crazy disease on top of it, the low-dose dex is most sensitive or more sensitive than the ACTH stem, so it's more likely to give you that positive answer in a dog that has Cushing's. The other thing is that it can help you differentiate between adrenal and pituitary dependent disease, which means you may not have to use as many tests as if you use the ACTH stem. Now, the ACTH stem works sometimes. The problem is that it's only 60 to 80% sensitive, meaning that if I'm looking at a dog and I'm certain that that dog has Cushing's clinically, there is still a 20 to 40% chance that the ACTH stem is not positive for Cushing's, and you've got to go back to doing the low-dose dexamethasone suppression test. The other thing is the stem doesn't differentiate between pituitary and adrenal or ACTH dependent and independent. So you end up having to do another test if you want to differentiate between those two causes.
And it's funny that you say we graduate vet school thinking that we do a lot of ACTH stims, because that is what I graduated thinking is, we always, do this ACTH stim. And I remember the first one I did out of vet school, the dog stimmed to like 40 something. I mean, it was really, really high. And I was talking to one of our internal med docs here in town. And I remember her telling me, like, I don't want you to think this is how this test works. Like, this is not usually the result we get with this test.
Yeah, that's a pretty distinctive number and answer, and definitive. That's the word I was looking for. Yeah, so that's the great thing about the ACTH stim is when it's positive, I feel very confident in the result. Again, considering all the other clinical signs. And that is one problem with the low-dose dex, actually, is that it has more false positives. So with the low-dose dex, you have to be sure that that dog actually fits those clinical signs, because some dogs without Cushing's will test positive on the low-dose dex as well. So if you have a dog that has concurrent disease, such as diabetes or kidney disease or something else going on, and you're worried about false positives caused by the increased stress, then that's where an ACTH stim comes into play as well, which is another reason here in academia where we have specialists, we get referred all these dogs that have 8,000 problems. So I don't necessarily want to do a low dose dex. I'm afraid I'm going to get a false positive because every dog that comes in is super stressed, and half the ones I diagnose with Cushing's have diabetes on top of it. So then I do the ACTH stimulation test. So there's definitely a role for it. And I feel much more confident in the diagnosis when the ACTH stim is positive because of the fact that it has a higher specificity, just a lower sensitivity.
And kind of the same story, like you were talking about with the urine cortisol to creatinine ratio, any additional stress is going to cause that to become positive. So a lot of times we're wanting those owners to get the sample at home when the dog is happy and not stressed, to try to make that test a little more accurate as well.
Absolutely. Very, very good point. And even pooling 2 or 3 samples together over a few days may make it better. Another thing I did want to point out, and when we talk about testing, to me as an endocrinologist, when I see a dog with Cushing's, I want to know whether it's pituitary or adrenal. Again, I'm in a specialty practice setting too, where our owners have generally more resources and dedication. So owners want to know whether it's pituitary or adrenal, because the best treatment for adrenal dependent disease, if you can do it, is to remove the tumor. So it's really important for us to differentiate between the two. Now, I accept that in a general practice setting, not everybody has either the dedication or the finances to push through to differentiate between pituitary and adrenal. And even if we did differentiate and find that a dog has an adrenal tumor, a lot of owners aren't going to either spend the money or put their dog through an adrenalectomy. So all of this comes back to the question I always get is, do I absolutely have to differentiate between adrenal disease or pituitary dependent or ACTH driven? And the answer is, in order to treat with Trilostane, you don't actually have to necessarily differentiate between adrenal and pituitary, and Trilostane is going to treat both of them. It does kill a little bit of my endocrine soul every time we end up treating a dog for Cushing's without differentiating, but I accept in the real world it happens.
Sure. Sometimes one of those limitations. And that segues perfectly into talking about treatment. You talked about the adrenalectomy for adrenal disease. And really, once we diagnose a patient with Cushing's, one of the tougher conversations that we have to have with owners is about the cost of care and treatment. So there's the cost of medication, follow-up testing, and monitoring. What are some of the ways that we can help owners understand the necessity and the value of treating and monitoring these patients? And do you have any pointers for us that can make that conversation a little bit easier?
Yeah, I think the biggest thing is getting owners to understand that my goal of treating a dog with Cushing's is to control their clinical signs and get them back to the dog that they used to be. I mean, obviously, I'm not going to change a 10-year-old dog into a 2-year-old dog, but at the same time, I think, even though we focus on the polyuria, polydipsia, polyphagia and such, there are other things that happen with our dogs with Cushing's. People that have Cushing's have, I think about 2/3 of them have mental health issues, such as severe depression. So sometimes treating our dogs with Cushing's actually results in them being more active and being more interactive and maybe playing with toys. I had a friend of mine, John, whose own dog his vet suspected that Lucy had Cushing's, and he called me up, and he doesn't know what I do other than I'm a veterinarian. And he said, hey, my vet thinks that Lucy may have Cushing's. I'm really worried about putting her through a lot of things that she doesn't need. And is this going to give her a good quality of life? And is it going to be worth it? And my answer was, absolutely. I think that treating her with Trilostane, especially now that we're using lower doses, I think treating them with Trilostane tends to control their clinical signs really well. We don't have as many side effects as we used to, either using higher doses or with Mitotane. And you may very well get your dog back. And a week later, I texted John. I'm like, hey, how's Lucy doing? And his answer was like, oh my God, this dog had not played with toys in a year. And suddenly Lucy's playing with toys again. And that was just fantastic because, again, we got back to, she had great control of clinical signs. She ended up living for, I don't remember, 2 or 3 years after that. These dogs are older dogs and they don't usually die from Cushing's, it's from something else. But our goal in the middle of that is to give them a good quality of life. And I think that's one thing to really stress to owners is that we're trying to get them back to what they used to be. And it may be that the dog has been slowing down and they didn't notice it, and will hopefully improve their quality of life. In the end, I'll be honest. I mean, if owners don't have the funds, they don't have the funds, and I understand that. But to me, improving quality of life is our major goal. And the other thing that owners need to know is, just because they start treating with Trilostane doesn't mean they have to continue it. So if they start and it's not something they want to continue because they run out of funds, or which hopefully doesn't happen, or they just don't feel like the dog is responding well, you can start it and then not finish. I mean, obviously the disease is going to continue and it's a lifelong treatment, but I feel like it's a lot less risk to just start the treatment, see how their dog does, and they may be like, oh, 2 weeks later, the dog's doing great. I wouldn't promise them the dog is going to be perfect in 2 weeks. I mean, it might take a couple months to get the dog really under control, but it might be a little less risk to tell them, hey, let's start it. And if it doesn't work for you, then we accept that.
Because it is like so many things in our pets where it can be this slow onset that we don't even notice. We see it with arthritis and things like that. Well, no, I think they're fine. They're getting a little older. They're slowing down. And then sometimes, like you mentioned, we get these really rewarding outcomes. So treat them, see if they feel a little bit better, see if you notice a difference, and then decide from there.
Exactly.
There are also some techniques that can help us regulate our patients a little bit faster. So along those lines, can you talk to us about how you dose Trilostane?
Sure. Yeah. The Veterinary label, I can't remember exactly what the dose is even anymore, because since they got the FDA approval, there's been a lot of research done looking at different doses and such. But I know the label says to start once a day. The thing is that Trilostane does not last 24 hours by any means in any dog. And a lot of times the best we're going to get it even is 16 hours. So when I started off treating dogs with Trilostane, I started once a day dosing because, I look at funds too. Remember, I live in Mississippi, and it's definitely less expensive to treat a dog with 60 milligrams once a day than 30 milligrams twice a day, because 30 milligrams twice a day, 2 pills cost more than the 160 milligram. So that was my approach to it. And I thought I was saving money, and, I'd do the rechecks and have to increase doses here and there. And that was fair and it made sense to me. But then I was involved in a study where every dog went on twice daily Trilostane. So again, instead of 60 milligrams once a day, I'd put them on 30 milligrams twice a day. And what I found out was, at least in my mind, the clinical control improved significantly faster than it did when I had them on once daily dosing. So I had much happier owners when I put the dogs on twice a day versus once a day. Now, I'm not going to say you can't get dogs under control once a day. And there's some people, I still have owners who, for example, one of my owners, when they were in that study, they actually got the drug for a much discounted price. When the study was over, they went back to once a day and the dog was fine on that. But there are other dogs that, again, I felt like I chose the dose right initially and it worked. And the dose that I use, I generally start at 1 to 1.5 milligram per kilogram twice daily. And of course, I adjust it based on the size of Veterinary pills available. So if I need to go up to 1.75 milligram per kilogram twice daily, then I might do that, or down to 0.9 mg per kg BID. I'll do that based on what pill size I have available. But it's also important to remember that this drug needs to be given with food. So make sure that the owners are giving it with food, whether they're giving it once a day or twice a day. The other thing is, if you do have owners giving it once a day, don't be like me and mess this up. Make sure they're giving it in the morning, because if you're giving the pill at night and the owner then is coming in later on for, say, an ACTH stimulation test, which you need to start, say, 3 to 5 hours after you give the pill, most people don't want to do stims at 10 o'clock at night. So make sure you give it in the morning, and make sure every time they come back for rechecks, you confirm that they're giving it in the morning. Because I've had some vets I've talked to before where the dog seemed controlled clinically, but the numbers were high. And finally, we got to the bottom of it. The numbers were higher because the owners were giving it at night. So make sure all that's clear. So twice daily, 1 to 1.5 mg per kg with food.
Yeah, I'm nodding my head over here because I've definitely done the once daily and then found out it was at night and been in that same situation where I'm like, oh, I didn't even think about that. So yes, good reminder to make sure we're dosing that in the morning.
Yeah, we had one that came from 2 hours away to get the stim in the morning. And then it turned out they were giving it at night. And we're like, oh,
Well, I have some bad news for you.
yeah.
Uh, so another area that can be difficult is monitoring and doing the repeat testing. But there's been some new data recently that kind of allows us to change how we monitor for Cushing's in some patients. Can you talk to us about how you monitor patients with Cushing's disease?
Yeah, absolutely. I think that when I talk about monitoring Cushing's, it's really important to look back at what our goals of therapy are. So my primary goal, I already said, is to improve quality of life. And of course, you're going to improve quality of life through decreasing the clinical signs, controlling the polyuria, controlling the polydipsia, panting, polyphagia, et cetera. So the first and most important thing for people to monitor in these patients is clinical signs. If the clinical signs are pretty controlled, we've already achieved one of our goals. Then, of course, the second goal of therapy as veterinarians, do no harm. So let's not oversuppress them and cause them to go Addisonian. So when I'm monitoring them, I want to check the clinical signs to make sure that the animal is actually clinically controlled. And then also check some cortisols to make sure that we are not either currently Addisonian or at risk of going Addisonian. Historically, we've used ACTH stimulation tests to monitor patients, and I know a lot of people out there are groaning because ACTH stims are not exactly the least expensive thing out there, and they're time consuming, and owners get really frustrated doing ACTH stimulation tests because of all these reasons. So actually, some researchers in Scotland came up with the idea of, hey, let's check a pre-pill cortisol, which is exactly what it sounds like. It's the cortisol concentration checked prior to giving the pill in the morning. And by checking that and doing some studies, one of them not published yet, but it seems to me that doing the pre-pill cortisol does a pretty good job at catching dogs that are currently Addisonian or at risk for going Addison. So when the owner comes in the morning, what we do is we give them, so we have them come in before they give the pill in the morning. They have the questionnaire to answer what clinical signs the patient's having. Our technicians take the dog to the back and collect some blood from them to check a pre-pill cortisol. And then we can send the dog home and they can get their pill and food at home. If their pre-pill cortisol is greater than 2, I can tell you that the dog is probably not at risk of going Addisonian imminently. So if the pre-pill cortisol is between 2 and 6, in my experience, they seem to be safe enough to continue the current treatment regimen. Now, if I get a pre-pill cortisol, especially at that 2-week recheck where it doesn't often suppress cortisol as much as it will later on, if I get a pre-pill cortisol less than 2, then either I'm going to decrease the dose a little bit by 10 to 20%, or I'm going to have them do an ACTH stimulation test. The biggest question for me with the pre-pill cortisol is, when is it safe to increase the dose if you have a dog that's not clinically controlled? Say that the pre-pill cortisol is 6. Well, in that case, I'm completely comfortable increasing the dose. If they'd stemmed to 6, I would have been completely comfortable increasing the dose. And I'd probably be comfortable with 5 or 4, but then I get down to between 3 and 4. I get fairly anxious about that, increasing the dose at a 3, definitely below 3. So then I feel like you either need to do stim, or if you have one of those dogs where you started them on once daily dosing, then if they're still having clinical signs and their pre-pill cortisol is say below 3, the first thing I would probably do is split the dose into 2. As I said, I feel that starting them on twice daily dosing gets them controlled faster. So even though it costs a little bit more, I don't have to do as many follow-up monitoring episodes. So in the end, it makes the client happier sooner, and it may actually be a wash for how much it costs, because the pill costs a little bit more, but less monitoring initially means it costs a little bit less in the long run.
And I like your focus here on, kind of basing our treatment off of the clinical signs. So the next question being, what types of changes should we look for in our patients to suggest that treatment's working? I like one of the things that I've heard you say in the past, which is we want to control clinical signs and not make them Addisonian.
Yeah, I mean, that's pretty basic for the way I think about it. I'm a fairly simple person, and it makes sense to me to have those two goals. So the most common changes we see are going to be a decrease in PUPD, and we will see those earliest. So decrease in polyuria, decrease in polydipsia. Obviously, the question to me becomes, why did they bring the dog in the first place? If they brought the dog in because it's having accidents, that's one of the things that we'll notice first, is whether the accidents are happening anymore or not, or them getting you up in the middle of the night. I have a dog that I have to get up in the middle of the night for all the time right now. I can tell you that if I were suddenly able to fix that, I would do whatever treatment you wanted for me to do long term, because it would improve my quality of life and his. But if it happened to be a derm problem, then look at the skin as well. The derm things are not going to get fixed as quickly as the PUPD. My recommendation for people who, for dogs that come in largely because they have skin changes and such, is to make sure the owners know those skin changes may not go away for 3 to 6 months. Now, I feel like the pyoderma will get a little bit better faster, definitely, but the alopecia, that can take 3 to 6 months to see changes with. So make sure you prepare owners for that so they don't get freaked out if in the first 2 weeks it doesn't.
Sure. I mean, so much of this disease is client communication. And one of the other things we have to speak with pet owners about is giving this medication, because, when you tell people, hey, you're going to have to give this medication, it's going to be twice daily for life. Of course, one of the first questions is, what are the side effects? So when we're treating dogs for Cushing's disease, what types of safety discussions should we be having with owners as far as adverse effects and how to address them?
Yeah, absolutely. That's really important. So there are kind of two classes of side effects I think about. One are the side effects associated with giving any dog an oral medication. Within the first few days of dosing, I've had some dogs that have a little bit of vomiting here and there. Usually if it's after the first pill or 2 or 3, I'm fairly confident it's because they just had some adverse effects to the drug. You don't necessarily have to check a cortisol the first 2 or 3 days if this happens. However, it makes me feel a little bit better to go ahead and do so. But what I'll generally do with them, I check the cortisols, you do or not, take them off it for a day or two, and then start them back on it, say half the dose or something. Because a lot of them that have the GI signs, I'll decrease the dose in half, and later I can increase it back up again. The other signs you see, of course, are due to too much suppression of cortisol. So Trilostane is absolutely a cortisol inhibitor. And if you inhibit the cortisol too much, then they can have signs kind of like Addison's. So the most common things owners will see is they're a little bit less active. They may not be eating as much. They may have a little vomiting or diarrhea. That means they need to not give the drug anymore and contact you for further questions. Now, my experience is, because this is the way a vet med, usually these happen on Saturday or Sunday. It's not usually going to happen on, Tuesday at 2:00. It'll happen on Saturday or Sunday. So assuming the dog is stable and only is a little lethargic or had an episode of vomiting or not eating, you can stop the medication, give a dose of dexamethasone that I've already dispensed with the Trilostane, and have them come in on Monday. And generally, I'll probably check a cortisol then, but of course they're not on Trilostane, so I don't really know. I don't really know what the cortisol means at that point. But if they come in for that reason, I'll check the cortisol, make sure they're not in Addisonian range now, and then start them back on the drug, say at half the dose or whatever. But when I give them the dexamethasone, I'll start them at 0.1 mg per kg. But that works. The other thing is, if you don't have dexamethasone available, that doesn't mean you can't give anything to the dog. So you can give prednisone at maybe half a mg per kg. The problem with giving prednisone is going to cross-react with the cortisol assays. So after you give pred, you need to wait at least a day before you do any cortisol testing. So if you don't have dexamethasone, can't prescribe it, that's fine. Send them home with pred. Just make sure you keep that in mind when you're testing for cortisol.
Absolutely. Well, this is, as we've talked about, a disease with a lot of moving parts and pieces. It can be hard to get a diagnosis and get these pups regulated, but really rewarding once we do. So thank you for all the tips and tricks to do that quickly and more efficiently and with as little headache for the pet and for the pet owner as possible. This has been a great conversation.
Sure. Thanks so much for having me. And again, I think the biggest thing to emphasize to clients is these dogs can have a good quality of life after you start treating them. And I find it so rewarding to treat these patients because they're these older dogs, and so many of them, the owners just notice their PUPD, and then suddenly the dog's playing with toys again. So that's super rewarding.
Absolutely, absolutely. And thank you to DECRA for sponsoring this edition of Vet2Vet. Check out the Spark section of vetfolio.com for more of our V2V discussions on various topics in veterinary medicine. And remember, if one animal is better off because of you today, it's a great day.